Here will be Carrie, the president of the ERS, and he will cover a very interesting topic, the future of sinus surgery. And I think this is a very interesting and attractive topic because with the use of the biologics and monoclonal antibody therapy, we will see what the future will be. Thank you.
Thank you very much. Thank you to Vitska and to Janis. Once again, welcome to the ERS conference. Future of rhinological surgery, the future of sinus surgery, the very future of surgery itself. I think I'm going to touch on some of that in this morning's talk. Jack Kennedy, the former US president, said, "Change is the law of life. Those who only look back are certain to miss the future." And in fact, we have the opportunity to have the past at our fingertips. We have the digital format. We have access to a repository of videos from the ERS meeting in London in 2018, and also all of our lockdown webinars that we undertook in the interim between that meeting and the present time. And so it's a fantastic opportunity to visit the past, because without visiting the past and understanding where we have come from, it's very difficult to predict where we're going to go into the future. Peter did a fantastic job of future scoping for rhinoplasty, and he alluded to the fact it's actually very difficult to future scope, to know exactly what's going to happen within the specialty in the coming years, because sometimes it's organic, isn't it? It just sort of happens, and we have to look back to see how that is going to happen. But clearly, if we future scope into sinus surgery, there are going to be lots of interesting things that you're going to hear about at the meeting in the next 3 days. Of course, we're going to hear about the novel medications, the new biologics, the new technologies which are taking place within our specialty, and the drive, the increasing drive and the relentless drive really towards miniaturization in surgical approaches. But I think we have to be cognizant of the fact, really, that healthcare spending around the world, certainly around the developed world, is outstripping personal incomes and is outstripping gross domestic product. So undoubtedly, and exacerbated by COVID, we're certainly going to see either a reduction in real spending, but certainly a reduction in apparent spending in the coming years. And Peter Duker, who is an Austro-American management consultant and educator, I think put this really quite nicely. He said, efficiency is doing things right. And I think in rhinology, we do that pretty well. We do things pretty well. We do things right. Effectiveness is doing the right thing. And I think in rhinology, and particularly in sinus surgery, we're perhaps not quite there yet. And I'm going to come on to this in terms of clinical effectiveness and cost effectiveness as I go through my talk. And of course, we're going to see increasing changes in attitudes, further patient and clinician involvement, as Peter alluded to in his previous talk. But I'm going to change tack slightly, because earlier this year I was up visiting my youngest daughter who's studying in Edinburgh, and we climbed Arthur's Seat, which is an extinct volcano, unlike the ones in the Canaries at the moment, which is a beautiful walk on a Sunday morning out of Edinburgh. And I was walking up there telling her that I was going to be giving this talk on the future of sinus surgery. And she quite succinctly put it, she said, "It's obvious, Dad, isn't it? It's the climate." And that really made me think a little, actually, because as clinicians, as surgeons, we very much look to doing the very best for our patients. But in fact, a lot of what we do is not necessarily very good for health and the climate in general. And I'm going to talk about this a little bit more. This is the interesting thing, of course, about climate change, is that it's largely related to the greenhouse gas effect. So you have the parallel with the greenhouse, where the glass traps the sunlight. Well, the same is true of greenhouse gases. And of course, carbon dioxide is the most potent of those. And as clinicians, we're involved in the production of a lot of carbon dioxide, as I'll come on to. And I think this is a really interesting graph, looking at global emissions from the 1900 onwards, so the beginning of the last century. And you can see that the first half of the last century, very little rise in CO2 output, but over the past 60 to 80 years, that has risen exponentially, and until, funnily enough, last year, when actually, as a result of COVID, it began to drop down a little bit. But unfortunately, it's on its relentless rise once again. And this graphic here really shows the change in mean annual temperatures from the beginning of last century through to the present time. And you can see that actually for most of that time, very little changed through the previous century. But as we got into the last 20 years, temperatures year on year have begun to rise. And in fact, in the last 7 years, we've had the 7 warmest years globally. And why is that important? Well, I think, to paraphrase the previous Director General of the WHO, a healthy planet and healthy people are two sides of the same coin. And I think that's really important for us as clinicians to understand. Because if climate change does carry on to the extent that it does, then we have serious concerns about deaths per 100,000 population. So if we look at climate change and high emissions there on the red graph, and number of deaths towards the end of 2100, we can see it would actually outstrip injuries and infectious disease. So these are really big problems that are facing us. And I really like this graphic that was in the Spectator magazine last year. And it shows, of course, COVID swamping us. But beyond that, the recession that we're in, and many of you will experience that recession. Many of our patients will as well. We're in the deepest recession since the Great Depression at the beginning of the last century. But beyond that, we have this third tidal wave. And actually, it's not really a tidal wave, because climate change is here already. And it's not a wave, it's a consistency. And it will be here, and it will be something that we're going to have to deal with as clinicians as time goes on. COP25 in December 2019, the Paris Climate Conference, was the first conference that actually achieved a unique aim. And all the countries who attended that conference agreed to try and limit global warming to 1.5 degrees C and to become carbon neutral by 2050. And that's really important, because if you look at this graphic on the right from the Carbon Brief, which is a governmental funded organization, it shows the differences of the impacts of 1.5 and 2 degrees C rise in temperature. And you can see how heat waves, heavy rainfall, sea level rises all increase, and crop yields begin to decrease to a much greater extent at 2 degrees C than 1.5. And this is clearly something that we have to focus in on. And we don't have much time to do it, of course. If we want to keep our temperatures at 1.5, then we have a 50% chance of doing that in the next 10 years, provided we keep our carbon emissions at the same level. So, where does healthcare fit into all of this? This is a graphic which really explores the UK healthcare carbon footprint. And I'm sorry, I don't have data beyond this. But the NHS, which is the largest public employer in the UK, contributes 30% of all carbon dioxide output in the UK. And you can see the sort of carbon footprint on that pie chart on the right. So about 13% is related to travel, so that's people getting to hospital, logistics, supplies, that sort of thing. About 15% is related to heating, ventilation, air conditioning. The rest, the 72%, is made up of stuff. And what sort of stuff is that? Well, if you look at the bar chart on the left there, in blue are pharmaceuticals, and a huge part of that is anesthetic gases. And I'm going to come on to that in a second or two. But a major component of it as well is related to medical equipment and surgical procedures. So going back to my very conversation with my daughter, you can see that really we do have a very significant impact in terms of carbon footprint. So what is our role individually and collectively? Well, the first point is well understood. I've shown you, and you will have recognized from your reading of the press, that climate change and health are inextricably linked. But we as clinicians are in a unique position. We understand the science, we're very influential, and we're very trusted. And we have a unique opportunity to explain that to our patients on a daily basis. There are thousands of us, tens of thousands, hundreds of thousands of us globally, and we can make a big difference. But we have to be aware of the consequences of our own decisions. Do we need to see that individual patient face to face? Does that patient actually need an operation? On a micro scale, you might think that's not very important, but of course, when you look at an audience, a hospital, an institution, a country of clinicians, it does become very important. We need to operate less. In the future, we need to operate better. And we need to motivate the individual patient, and not motivate them so much about climate change. It's motivating them about the impact that climate change is going to have on their health and the health of their children. So what can we do on the right there to reduce carbon without reducing the impact on health? Well, we can either reduce activity or we can reduce carbon intensity. There are three options in terms of reducing activity. We can prevent disease, which is perhaps the most important of all. We can empower our patients to understand their conditions better and self-manage. We can develop lean pathways. We can look at low-carbon alternatives. And this slide really is and it comes from the Centre for Sustainable Healthcare, and I would recommend it to those of you that are interested in sustainability in healthcare. So let's explore these individually. So prevention is clearly very important. That's very much a big public health issue that's beyond rhinology alone, and in fact, it tends to move at rather a glacial pace. But you'll remember, for those of you that attended the meeting in London, that we had some very good talks on prevention from Witske and Professor Fawkins and Professor Claire Hopkins. And Claire talked particularly about primary prevention, so in fact preventing the condition arising, secondary prevention, preventing it from getting worse, and thirdly, tertiary prevention, preventing the complications and the morbidities associated with that. And of course, we've got a big role to play in that in terms of smoking and alcohol, but also in occupational airway diseases, and increasingly so in environmental airway diseases. In the UK, there's an increasing recognition about the impact of air pollution. There was a young girl in South London who lived very close to a busy road in an urban area, and she unfortunately died with an exacerbation of her asthma. And this was the first time that a coroner in the UK contributed to the death of a child to environmental emissions. And I think this is something clearly we're going to see more and more of. Secondary prevention is really important, and here we've got the place of our support societies, for which there are many. We've got to upskill our future clinicians, our medical students, our primary care colleagues, and our secondary care colleagues to better understand our rhinological diseases. And of course, we have digital solutions for our patients. We have the Hostbloom app, which looks at allergic rhinitis, and the My Sinusitis Coach. And both of these apps have published evidence to show the impact this has on improving patients' health in terms of better understanding of their own health, better communication with their clinicians, and better overall monitoring of their condition. So we've got a lot to look forward to in terms of digital improvements. Peter touched on a little this in his previous talk in terms of developing better service models. And in fact, we've seen this through the COVID-19. We've seen the move towards virtual consultations. And whilst they haven't been popular, of course, it has a major impact in reducing patient attendance at hospital, which in turn has an impact on the carbon load. And we can do that better with pre-assessment, with prehabilitation of our major cases as well. We need to think about operating differently, and we will come in the symposiums itself, in the meeting, to talk a little bit about local anesthetic procedures. And of course, the advantage of a local anesthetic procedure is it's much less carbon intense, and it doesn't tend to impact in terms of anesthetic gases. And once we've done our operations, are our follow-ups really necessary? Do we need to continually see the patient, or can we see that patient virtually? waste is a big problem in surgery. On the right here, at the top, is I did a small endoscopic procedure last week, and I just took a photograph of the waste from that procedure. And you can see recycling waste on the left, you can see biohazard waste in the middle, and laundry on the right-hand side. Now, the WHO reckon that we can recycle 90% of the waste from theatre. And how much waste from your theatre gets recycled? Well, I can tell you from our operating theatres, very, very little. So who's going to make that change? Well, it's up to me to make that change. It's up to you to make that change as well. As clinical leaders, we are absolutely in the position to invoke these changes within our departments. And if you think about the amount of waste there, think about a major head and neck resection or a major skull-base case. You can multiply that waste 5-fold, 10-fold. And so much of it ends up going to landfill. We need to go back to reusing equipment, reusable drapes, reusable gowns, reusable metal containers rather than disposable containers. We need to recycle better, and we need to repair. I remember when, as a young surgeon, when an instrument was blunt, it went off and got sharpened. What happens to instruments now? Well, they tend to get thrown in the bin, and we buy new instruments. Surgical instruments are carbon intensive, and they tend to be produced in countries where the ethics around producing in the third world are very circumspect. Surgery is very carbon intense, and that's largely for three reasons. Anesthetic gases, the supply chain, heating, ventilation, and air conditioning. And if you think the typical operation probably costs around about 150 to 250 kilograms of carbon dioxide. Now that doesn't mean very much, but it's about equivalent of driving 500 miles in a typical family car. And this is a really interesting study, I think, from one of the Lancet publications published in 2017, looking at the carbon load from 3 individual centers. On the left, we've got a center in Canada, in the center from the US, and on the right-hand side from the UK. And just comparing where those sort of carbon hotspots are for each of the centers, we can see that for the 2 North American centers, the big hotspots are anesthetic gases. And that's because in the US, and my understanding, and certainly from this publication, is that desflurane tends to be the anesthetic of choice. It allows a very rapid induction and a very quick emergence from anesthesia. But it's a very potent greenhouse gas. It's 10 times more potent than isoflurane and about 13 times more potent than sevoflurane, which are the anesthetics of choice within the UK. So that has a fundamental impact on how we should be thinking about providing our anesthetic services if we really do want to continue to give general anesthesia, which of course we have to. And also energy. You can see big differences in the proportion of energy. In the UK, the hospital in the UK has very inefficient heating and air conditioning system, and a lot of that energy came from coal-fired power stations, whereas the Canadian centre, much of its energy came from hydroelectric and was very efficiently used in the hospital. So these are real challenges for hospitals. They're complex, but we need to better understand them. And these are going to become so much more important in such a carbon-intense procedure as surgery. I'm going to come back a little bit to clinical effectiveness, because that's something that we as nasal surgeons have struggled a little bit. Clinical and cost effectiveness. It's quite difficult to measure these for a lot of the softer procedures that we do. We don't tend to deal with a lot of cancer. A lot of ours are sort of softer conditions. We need to look at medical versus surgical options, and I've already alluded to taking surgical instruments from overseas. This graph here is a graph of septoplasty rates in the UK in different geographical areas, different commissioning groups. And you can see that the rate of septoplasty varies from 83 at one end of the graph down to 5. So there's a huge variation in the number of septoplasties. And that can't just be a case mix issue. And commissioners are rightly asking the question, well, if this is an operation with so much variation, then is this an operation that really needs to be done at all? And what are the guidelines for it? And what's the effectiveness of it? And these are big questions that are going to be asked more and more. And we're beginning to develop the evidence. We've got clinical effectiveness trials on nasal polyp surgery or chronic rhinosinusitis with nasal polyps versus medical treatment. We've got the NEROS trial looking at septoplasty versus medical management, and there's already a Dutch trial which is reported on outcomes associated with that as a separate issue, and the macro trial looking at macrolide therapy versus surgery. And there are more of these which we haven't alluded to, but these are really important trials. They're really important for our patients in order that we can develop the evidence, the clinical effectiveness, the guidelines coming from that, and the associated cost effectiveness. Now, intuitively, we think that actually surgery is probably more carbon intense than medical therapy. And this was a study in the International Journal of Surgery from about 10 years ago. And it was a study undertaken on gastroesophageal reflux, which actually mirrors much of what we do in rhinology, because there is some controversy as to whether surgery or medical therapy is best. And it looked at financial costs and it looked at carbon emissions. And if we look at financial costs there, the purple line at the top of the graph there is the financial cost of surgery. It obviously starts out high because it's costly to undertake surgery. But if you look at medical treatment for gastroesophageal reflux, it starts out much lower, but after a period of about 12 to 15 years, the graphs intersect and medical therapy becomes more expensive. And the same is true for the carbon footprint of that particular treatment, in that surgery is very carbon intensive initially, but becomes less so as time comes on, whereas medical therapy becomes more carbon intensive. And whilst this is modeling data, it's really interesting, isn't it? Because it's counterintuitive to what we might think. So what can we do as a society? What can the ERS do? Well, we can declare a climate emergency. What's a climate emergency? It sounds rather glib, doesn't it? But in fact, a climate emergency is essentially us saying that we understand the impact of climate change on health, we are concerned about that, and that we want to take urgent steps and develop strategies to mitigate it. So how might we do that? Well, the ERS has moved very much towards virtual committee meetings, so very few meetings held face-to-face. Our conference this year is a hybrid conference, and maybe this has to be the model for the future. And I suspect the younger delegates within the audience will feel much more strongly about that than perhaps some of the older ones. We really need to promote research into sustainability in rhinology and in sinus surgery. How can we continue to treat our patients to the best that we can at the lowest impact from a carbon perspective? Richard Smith is the ex-editor of the British Medical Journal. He's now the chairman of the UK Health Alliance on climate change, and I really like his thoughts on what I can do as an individual, because it does come down to what we can do as individuals as much as what we can do collectively. And he says we should move better. So we should cycle more, we should walk more, we should drive less, we should take the train more and fly less. We should eat better, less dairy, less meat, more fruit, more veg. We should buy better. We should disinvest in fossil fuels and invest in sustainability. We should talk better. Not talk about climate change with our patients, but talk about the impacts of climate change on health and the importance from a health perspective. We should listen better. And we think, well, carbon offsetting is the answer. We can carry on as we want. But carbon offsetting is not the answer. This is not the excuse to carry on as normal. We have to bring down our levels of carbon and greenhouse gases. And we can do that very effectively. And yes, we can carbon offset. But we can't plant trees forever. And we can't sequester carbon in rich soil. We can only do that to a limited extent. And we haven't yet got the technology for pulling carbon dioxide out of the sky. And the problem is that most carbon offsetting affects the poorest members of society. So allowing us to fly essentially means that somebody in the third world has to change from standard light bulbs to LED light bulbs. It's clearly not right, is it? So, from Edinburgh to Glasgow to COP26, which was within the next couple of weeks, and the aims of COP26 are to ensure that we are carbon neutral by 2050, and that we're on track by 2030. And also to ensure that we have 100 billion per year invested in developing countries to allow them to make the necessary changes. These are big asks, and we must wish our political leaders all the very best for these challenging decisions. And I'm going to leave you with one last slide. This is the Greta Thunberg effect, and my apologies to my Scandinavian friends, but this is an article that appeared in The Economist last year, and essentially it looks at Fridays for Future, which was Greta Thunberg sitting outside the Swedish Parliament protesting about climate change. And she had a major impact, or associated with that was a reduction in air flights out of Sweden, in fact, out of most European destinations, and that was before COVID. I think the term was flag scam. My apologies, my Swedish is not very good. Flight shaming. So, ladies and gentlemen, I thank you very much for allowing me to give my talk, and I wish you all the very best in your future sustainability drive and for the remainder of the ERS conference. Thank you.
Thank you very much, Sean, Peter, for two thought-provoking and excellent talks. We will now have a short break. Please, everybody, think of COVID rules while you meet your friends. And we see each other in one of the halls back at 10:15. Thank you very much.